My name is Chloe Hutchins from the London School of Hygiene and Tropical Medicine, presenting on behalf of a large collaboration with Johns Hopkins University and in-country partners on Vibrio cholerae rapid diagnostic test performance analysis in Uvira, Democratic Republic of the Congo. So I know we have a mixed audience here today, and I will begin by explaining what a cholera rapid diagnostic test is, or RDT, but the clue is in the name. It is a quick test to perform for clinicians to understand whether or not they might be dealing with a cholera patient. The tests can take anywhere from 15 minutes if you're testing stool directly, up to 6.5 hours if you're performing an enrichment, for example, of a rectal swab. The results are very clear and easy to read, so there's no downstream analysis required. And it's very similar to reading, for example, a lateral flow COVID test or a pregnancy test. They're deployable in challenging settings because they are very simple, as mentioned. They're easy to train people on, they're lightweight, and they have good temperature stability. By comparison to other diagnostic methods such as culture and PCR, where it can cost somewhere between $5 to $17 per sample, RDTs cost roughly $2 per sample or less, not including import charges, of course. RDT performance has been described throughout the literature, and it's been found that there is high variability in performance, particularly specificity, depending on brand, test protocol, gold standard, and study setting. The WHO does not have a pre-qualified RDT make-or model. So it's really important to test the RDTs that you're going to be using in an outbreak setting or for a study setting within the context of that study to understand the performance of the test that you are using. In order to evaluate performance of RDTs, we use two measures, sensitivity and specificity, which I will go on to explain. Sensitivity is the performance of a test when you have a true cholera patient. And specificity is how that test performs when your patient has something else. They're not ill with cholera, they're probably in with E. coli or another diarrheal disease. So when we talk about high sensitivity, we mean that the RDT is telling you your patient has cholera. And we have two other options here, culture. So this is an agar plate with yellow Vibrio cholerae growing on it, or PCR. So this is a gel electrophoresis that's been run, and you have bands here showing that the PCR is positive. So in this case, for high sensitivity, the test tells you your patient has cholera, and so does culture and PCR. So we have high true positivity. High specificity is when the RDT is telling you your patient does not have cholera, and the culture and PCR test also confirm there is no cholera there. Low sensitivity is when the RDT test is telling you your patient does not have cholera, but the other tests, culture and PCR, are telling you that you do have a cholera patient there. So we're saying that low sensitivity is when your RDT tests give you high levels of false negative results. And low specificity is when your RDT test is telling you you have a cholera patient, but in fact, when you test their samples through other means, you don't have a cholera patient there. So low specificity is when you've got high levels of false positive results. I want to share with you two aims of this study. One was a field evaluation of sensitivity and specificity of the brand Crystal VCO1 RDT in Uvira, Democratic Republic of the Congo. And the objectives to achieve this aim were to investigate the performance both within and outside of outbreak periods. So this was from August 2021 to September 22, using a combined gold standard of PCR and culture to calculate the sense and spec of the RDTs. And the second aim was to perform an evaluation when we had improved culture methods in Uvira to see how that would influence RDT performance evaluations. And we did this by comparing only outbreak data of last year and this year, and using only culture results to calculate the sense and specificity. So I believe there may have been a talk on this study setting already today, but this is Uvira. It's a lakeside city in eastern DRC. It borders Burundi, is quite close to Rwanda. But the take-home message here is that it's been a hotspot for cholera for some time, and you can see that between November and February, year on year, we have outbreaks of cholera. When we have patient samples, we take two types, a rectal swab, which is then enriched for 6 hours, and an RDT is performed. We also were then preparing filter papers, which would be shipped away for culture to a general reference laboratory. We also collected stool samples, which could immediately be tested by RDT, and then samples prepared for shipping for culture. And also the stool sample was spotted onto dry filter paper, which was shipped to Johns Hopkins University in the US, DNA extracted and PCR performed. So for last year, we're looking at this kind of date range from August 2021 until September 2022, and you can see here the peak in cases around November to February. When we use combined culture and PCR as a gold standard, what we mean is that in order to call a sample positive, it has to test positive by one or the other or both. So it could be PCR positive and culture negative, and we would call it positive, vice versa. But in order to call it a negative sample, both PCR and culture had to test negative. What we saw was not really much of a surprise. It is in line with what's in the literature, and that is to say that the enriched samples had higher specificity than direct samples. And we already know that this is a phenomenon that basically enrichment reduces the possibility of obtaining false positive results, and therefore you end up with higher specificity. And just by comparison, we did in fact test another type of RDT, which was the crystal VC01 and 0139 combined test. And this is just to say we saw very similar sensitivity and specificity and similar results between enriched and non-enriched samples. So last year we were culturing from wet filter papers at a regional laboratory that was more than 7 hours away from our study setting. The filter papers were being stored anywhere from 7 days to beyond 100 days before culture was attempted. This is a recipe for false negative culture results. That is to say that whilst those samples are sat on the bench waiting to be analysed, the bacteria are becoming non-viable. And when you have this scenario, you're at risk of falsely reducing your RDT specificity because your gold standard of culture is not working so well. But however, this year we've installed a culture laboratory in Uvira, and culture is performed both directly from the sample, so not from filter papers, and almost immediately on the same day or the next morning of the patient sample collection. In improving culture, this has allowed us to feed back to clinicians and public health bodies more quickly, and not only relying on RDTs. One of the reasons for doing this is we cannot only rely on PCR, because PCR can take a very long time to run, especially if you do not have PCR capability on site. And we're also increasing the chances that we will retain Vibrio cholerae isolates for downstream processing later. And this is just for reference. This is the laboratory space in September 2021 for a wash evaluation, and this is now functioning as a culture laboratory. We can see contamination in the air, which we're able to control in order to keep a sterile environment. So these numbers will differ slightly from what you've already seen. And I'll remind you, this is because we're looking specifically at this data set and this data set and none of the in-between. But essentially, the impact of direct culture versus culturing from filter paper with all those kind of suboptimal conditions and timelines is that specificity has increased. And we have also seen an increase in sensitivity. But this does come with a massive caveat in that, firstly, we do need to check these results by PCR, which is in process, and we will be publishing the updated sense and spec of this year's RDT evaluation when those results are available. But the other is that this highlights that you should use caution when using culture alone to perform an RDT evaluation. So in summary, regardless of the RDT test type, using a combined gold standard of PCR and culture increased the specificity performance evaluation of the RDTs, that suboptimal storage conditions and delays in culture can negatively influence RDT performance evaluations, and that just a reminder more than a summary, the RDT tests themselves weren't really influencing these changes in performance. It was the choice of gold standard that was important to make this evaluation. We are commencing PCR work on all the samples from this year to further compare both the performance of the RDTs with the combined gold standard, but also looking at the sensitivity and specificity of culture on its own compared to PCR as a gold standard. And just as a comparison, last year we saw about 57% and 76% respectively. I'm looking forward to seeing what those numbers look like now that we have direct culture. Thank you for your attention. We'd like to acknowledge particularly Hanmeng, who is from Johns Hopkins University and performed the data analysis, and for our extensive teams across the Uvira Health Zone, INRB Goma, and the national cholera team in the DRC, as well as our logistical partner Oxfam and all of our funders. Thank you.